throwing so much of light on the subject, individual symptom management, and also we have had extensive, elaborate information on how to tackle each one in various aspects. We have been into total management. It's not one issue management. So, God's grace, we are heading into the right direction. And today, good evening and warm welcome to Dr. Rajani Surendar Bhat, who is a consultant physician and pulmonologist at boardofdoctors.com. And she has obtained her residency in internal medicine and fellowship in pulmonary diseases and critical care medicine from New York, Albert Einstein College of Medicine. And she's also an elected member of the Governing Council of Indian Association of Bronchology. And she is one of the important thing is, next what I'm going to say, she is the leading person, she's a mentor in Death Over Dinner India, which is essential for palliative care. And her areas of interest are very wide and varied. And she is an interventional pulmonologist and also she looks into ILD, which is one of the important thing in palliative medicine. And she's also interested in end-of-life care and burnout, which is very, very important thing. Everyone should be aware of burnout to save ourselves and save everyone. And similarly, and her other interests are in medical law and ethics too. So she's just not a person who is into one aspect. She is into education, research, and active implementation of practices. A warm welcome to you, Dr. Rajani Surendar Bhat.
Thank you, ma'am. Thank you for the warm welcome. Always a pleasure to be back with Pallium India, and I always like seeing all the new faces and as our tribe grows of people who are going to carry on this work of bringing more and more access to palliative care across India and across the world. So, warm welcome to everyone who's becoming part of this growing tribe. As ma'am said, my interests in palliative medicine grew out of my work in pulmonology and critical care medicine. You take up a field when you are young and you're like totally blown away by all the high-tech stuff that we can do in medicine. ICU, intervention, oh, there's no end to what technology and medicine can do. And then you start dealing with chronic diseases. And as you see more and more patients in your everyday life, you realize that there are many places where our training, our background in MBBS and our internal medicine, pulmonary critical care intervention, nothing taught me as much as I needed to truly walk alongside my patients and hold their hands and support them when these technologies and interventions and very expensive medicines could not help them anymore. And that's when I took up the study of palliative medicine, initially just in terms of trying to upskill myself in the field of pulmonology itself for palliative pulmonology. And a couple of years ago, I did my fellowship in palliative medicine. I did my FCPM as well. So now I can proudly say that I am also part of the palliative medicine physicians community of India. And I have to say that it has been a truly, enriching experience to go through the fellowship because it's added a new dimension of care that I am able to provide for my patients. I feel less helpless as a specialist doctor. I feel like I am a more complete doctor, able to provide care not just for the patient, but for the family or the caregiver, and also come to acceptance and be able to take care of myself. As Dr. Radha mentioned, burnout is a reality that we face these days. So awareness and acceptance is one of the important parts that to know that we must take care of ourselves while we are taking care of our patients and families. And that's the only way of providing high quality care to them as well. With that, I will begin our presentation. And today we'll be discussing, I'll try and give a brief overview on respiratory symptoms. I know you would have probably had plenty of um, interactions about pain and other complex symptoms as well. What we'll try and do is use that same framework, that same approach. So I want you to keep that same palliative medicine hat on while we approach respiratory symptoms. You'll find that the same principles apply. When we are addressing any symptom in respiratory symptoms, you can still approach it from the physical, psychosocial, and spiritual lens that we do for pain and other symptoms, right? So just give me a moment while I set up my um, presentation. One moment. Are you able to see my screen?
Yes, we can.
Okay. Oh, thank you so much. So today we'll discuss palliative care in advanced respiratory disease. And I put respiratory and systemic both in there because I just want to keep in mind that we actually address respiratory symptoms not just in diseases where the lung or the airways are the primary organ affected, but in many other diseases as well, which affect the heart, the kidneys, the liver. Breathlessness becomes a common symptom across all end organ, advanced end organ failures and diseases. So we look at the scope of palliative care and systemic respiratory disorders, and that includes very often when we look at palliative care, people focus in respiratory disease on COPD, ILD, pulmonary hypertension, and lung cancer. But infectious communicable diseases are also something that comes under the purview where we need palliative care integration into management, understanding that drug-resistant tuberculosis has a huge burden of symptoms for patients as well as caregivers. And the disease in terms of the burden it places on the patients and their families is comparable to cancer when you look at drug-resistant tuberculosis. So we'll try and understand what is this burden of breathlessness and other respiratory symptoms. And we'll try to see what are the issues that come up as barriers sometimes amongst patients as well as amongst doctors and caregivers. India is home to 1/6 of the world's population, right? But we carry 1/3 of the total burden of chronic respiratory disease in the world. This is based on a pretty recent, very comprehensive study taken up by Dr. Sandeep Salvi and group. And this was a Lancet study, longitudinal, long-term study. And these numbers sort of shake you up a bit, right? We are home to 1/6 of the world, but 1/3 of the global burden of chronic respiratory disease, which means compared to any other country, we are carrying twice the burden of respiratory disease. This photograph that I put here in my mind represents the impact of chronic respiratory disease on patients and their families. In the way I look at it, the the young man who is pulling the cart is the caregiver. The gentleman who is behind, exhausted, leaning on that cart for support is the patient who has carried the burden of his disease for a very long time, is now breathless, not able to walk without support, and needs the help of the family, of the community to help them now carry these burdens of multiple symptoms, physical and psychosocial. So COPD is the third leading cause of death in the world now. And the interesting thing is that patients have a 5-year survival after diagnosis of more than 70%, which means that if you are a person who say you've been a chronic smoker and you're diagnosed with COPD, you're probably at the point of mild to moderate disease at the time of diagnosis. But the next depends on what your many other comorbidities and factors and ongoing smoking, all of those things. It means that you live with the symptoms or you live with the disease for a much longer time period than many malignancies and other terminal illnesses that patients may suffer from. 27% of the world's new TB diagnosis is from India, and 24% of the world's drug-resistant TB is in India. So again, we are 1/6 of the world, but we carry 1/4 of the world's drug-resistant TB. And so overall, death due to TB is falling, but the success rate of treating MDR-TB, multi-drug resistant TB, is not very high at all. It's 55% and it's lower in India. What does this mean? Again, it means that patients are living with a disease which leads to isolation, social stigmatization, high cost of medication in terms of money, as well as side effects due to the medication itself. So this is the problem statement of chronic respiratory disease only with the two most common diseases that we encounter, COPD and tuberculosis, right? And there's so many more diseases that come under the umbrella of chronic respiratory disease. What is the best case scenario that we can think of in a very ideal healthcare system? So if you look at Europe and the Scandinavian countries, which have nationalized healthcare, which have palliative medicine access to patients as part of nationalized healthcare, there's studies that were done to look at comparing what is it like for COPD patients versus cancer patients. And the studies were shocking and revealing that the patients with COPD, now you have a chronic respiratory disease, obviously breathlessness is part of your symptom. We know that anxiety also follows because of breathlessness. The patients with COPD, they suffered more from these symptoms. They were not given as much medication for relief of breathlessness. And they ended up with lower rates of complete relief of these symptoms as compared to patients with cancer who were also oxygen dependent. So you have a patient who's on oxygen for COPD, you have a patient who's on oxygen because of cancer, which has led to some respiratory compromise. The patients with COPD are not receiving the right amount of palliative care for relief of their symptoms. Even in other advanced pulmonary diseases, if you look at it, it goes on even for ILD and pulmonary hypertension. Continuing with the same study, death was an expected outcome in 80% of those COPD patients, and like those patients with advanced cancer. But the COPD patients did not have access to home care services, palliative care, or hospice services. There were fewer end-of-life discussions in patients with COPD. They were more likely to die in hospital. They were more likely to die in ICU. They were more likely to be ventilated. That is the state in a country which has nationalized health services as well as palliative medicine services available to patients. So clearly, there is a lot of work to be done. And I'm glad that our national healthcare program is now acknowledging the need for palliative care. I'm glad that our national guidelines are now including the need for palliative care for patients with drug-resistant TB as well. So maybe a little late, but very welcome that we are all starting to embrace the need to integrate palliative medicine into pulmonology care for chronic respiratory symptoms. Palliative care in respiratory diseases has to address the respiratory symptoms of patients with cancer and non-cancer diseases. And we must also look at palliating the non-respiratory symptoms in advanced respiratory disease. So we spoke about how anxiety and pain are also symptoms that were not addressed adequately in that Swedish study. There are many symptoms besides breathlessness which patients with advanced respiratory disease will face, and those symptoms all need to be addressed. As I mentioned earlier, palliating respiratory symptoms in other end organ failures. So we know that breathlessness will accompany end-stage heart failure. We know breathlessness will accompany end-stage renal failure, end-stage liver disease, neuromuscular disorders. Patients will have aspiration. Patients will have hemoptysis in certain conditions like end-stage liver disease as well. Eventually, when we say that the final pathway for death, except in brain death for everyone else, is some form of a cardiorespiratory arrest, whether the cardiac death comes first or cessation of respiratory activity comes first. Since life-sustaining treatment, ventilators are an important part of life-sustaining treatment, all end-of-life discussions involve respiratory issues. So when we're talking about whether a patient qualifies for any kind of life-sustaining treatment, or if it's not medically appropriate to offer life-sustaining treatments and interventions, then we must also, when we tell somebody that it's not an ideal situation, that we know this is anticipated, that death is anticipated, and being on a ventilator is not going to change the outcome of a reversible, if it's not a reversible illness, then we must make sure that we offer palliation along with the option of let us not choose a ventilator, right? So it is not okay to say do not ventilate and leave the person breathless without offering them the medications and support needed to alleviate the breathlessness. The respiratory symptom complex, for the longest time, it used to be that people would talk about us as pulmonologists. As we know what's in the end, all you guys do is give bronchodilators and steroids, and what else is there, right? That there's COPD and asthma and tuberculosis. Of course, we know now that there's a huge complex. It is a complex system which works in parallel with all the other organ systems like the cardiovascular system and the renal system. So the symptom complex, we understanding it far better now. The field of pulmonology as a subspecialty of internal medicine has evolved, and so has the understanding. In some ways, the COVID-19 pandemic helped people recognize that there is a greater variety of illnesses, and there are nuances to treatment of these symptoms and conditions. So the symptom complex includes breathlessness, hypoxia, cough, management of secretions, hemoptysis, which is one of the most dreaded symptoms. It is very distressing. Going on to the specific issues of respiratory failure when patients need some kind of oxygen or ventilatory support, pleural effusions which require interventions, or airway obstruction which may require an intervention of some sort. And as I mentioned, patients with advanced respiratory disease, chronic respiratory disease, experience many other symptoms. They experience pain, they experience nausea, constipation. With advanced disease, there is anorexia, muscle wasting, and cachexia. Their sleep is disturbed. They experience dry mouth. They experience anxiety. They experience depression. They have loneliness and isolation. Now, it's not only patients with tuberculosis and drug-resistant tuberculosis who suffer from the loneliness of isolation, or patients with COVID-19 who suffer from that. What ends up happening is many of our patients with chronic respiratory disease, they've been a very active person who's out and about every day, going to the market, buying vegetables, cooking up a big meal for their family, or going and running all kinds of errands and being a very active person in the community. And as they get breathless, as they require oxygen, their life shrinks down to the boundaries of their home initially, and later on just their room maybe, because walking more than that is something that causes a lot of breathlessness. So that makes them more and more isolated from their social, from their community, from their social support system. Some patients will experience a lot of guilt because maybe one of the contributing factors or the risk factors for their disease might have been something like smoking. So they experience guilt because maybe there is someone in the family who says that, you brought it on yourself, or maybe it's their own feeling from inside that, oh, I could have avoided this. And it is not our place to judge anyone. So I think it's a very important thing as a palliative medicine practitioner to use non-judgmental language. So one of my interests is communication, and I like the concepts or the basic principles of non-violent communication, is how it's said. So it is, you look at substance use as a condition. So a person has been a tobacco user. When we say smoker, non-smoker, former smoker, somewhere there's a label attached. So you can, yes, when you choose to document in your records, you may use terminology, but be very conscious about the words we use when patients are listening to us, because sometimes that can add up to their feelings, the psychological distress that they face with guilt as well. One of the issues that comes up with pulmonary diseases especially, is that, breathlessness has been such a difficult symptom to treat for so long that patients will come and tell you, I'm breathless. Doctors will do their tests. They will do their lung function test. You'll check saturation. If you're a patient with ILD or a pulmonary hypertension, they may check the CT scan and the echo. They'll monitor numbers, and they will change your medication prescriptions and adjust it. But really, we need to spend time listening to what the patient is saying as to how is this impacting my life. So we should be treating not just numbers of saturations and peak flows and PFTs and CT scans and 6-minute walk distances, but we have to treat the patient as a whole along with the caregiver to understand how is this disease impacting them, how is it affecting them, and then try to provide a comprehensive plan to address the impact of chronic respiratory symptoms on their life, right? So that's why I like this cartoon where the patient takes the stethoscope, the chest piece of the stethoscope, and then takes it off his chest and puts it to his mouth, saying, Doctor, listen to me, listen to what I'm saying to you. So it's important to listen to the patient and their experience as much as it is to auscultate their lungs. Let's have a little tiny break from the presentation. I want all of you to join me in trying to understand what breathlessness is about. I'm going to check and see if one of you can just tell me, are you able to also see me in a little window on your screen along with the PowerPoint presentation? And can you see my hand go up
No,
and down?
No, ma'am.
All
No,
right.
Rajani.
Okay, let me go back to, I'll just stop screen share for a second and then I'll come back to it. Okay, so just give me a second. I'll come back to it in a second. You can see me now?
Yes.
Yes, okay.
Yes, ma'am.
And what I'd like you to do, all of you, is to find a comfortable seated position and just take a deep breath. Take a deep breath in, inhale, fill your lungs up with air all the way to the top and then all the way, right? So if you can watch my hand and just take a deep breath in and out. All the way up to the top again, in and exhale only once. In all the way up to the top and only exhale. In all the way up to the top and only exhale. In all the way up to the top. Exhale only once. Are you guys doing it along with me or am I doing it alone? In all the way up to the top. Exhale only once. Let your breath out. Release. You can breathe easy. Okay? Breathe at your own comfortable pace and volume. Take a deep breath all the way up to the top. Bring it all the way down. Empty, fully empty. Only 1/3 in. Out. In, only 1/3. Out. In, only 1/3. Out. In, only 1/3. Out. And now you can breathe now. Relax. Can someone share what that experience felt like? What did you feel with it? Just a 5-second, 10-second sharing. Did that feel okay or did that feel like, something's not quite right?
I felt little uncomfortable.
You felt uncomfortable. Okay.
Exertional.
All right. Exertional. Okay. You could feel the effort of breathing, right?
Right.
So what I want you to keep in mind is we were comfortably at rest while doing this little exercise. Now imagine if I asked you to walk, do your normal activities, climb your stairs, get in and out of, a bus, pick up your child, right? Carry the load of clothes to dry them, right? Do your gardening, move furniture with only that 1/3 volume of breath in and out, either up at the top or down at the bottom. So up at the top is the experience of a patient with emphysema who's hyperventilated. They're up there. And ILD, restricted lung volumes, that's the person there. We were uncomfortable sitting in a chair. If we were to do that day in, day out, week after week, month after month, year after year, 5 years, 8 years, that is the life of my patients. Okay, that is the breathlessness that we are looking to try to relieve to some extent. That is our goal as palliative pulmonology. I'll go back to sharing my slides again. Okay, so breathlessness is basically an uncomfortable sensation, as some of you said, and it's a sensation of unrewarded breathing. You are trying to take in a breath and you feel like it's not really quite okay. So we've all experienced it in brief spurts, right? Like you would have been late for a lecture or an exam and run for it, and then run before the bell rings, or run to catch a bus or a train. And so you put that burst of effort. Um, you're able to increase according to the demand of the body, and you feel breathless when you reach the top of the stairs, when you manage to catch the train. But after you rest for a few minutes, it comes back to normal and you're able to breathe where your hunger for air, your need for air is satisfied. So it is rewarded breathing as opposed to unrewarded breathing effort. Right? Now, what our patients with chronic breathlessness will experience is unrewarded breathing for a long period of time. So that changes fundamentally many things within us. And you would have learned already about pain, that chronic pain shifts many things within us, right? The experience of chronic pain will lead to certain maladaptive things as well. And this is what we notice with breathlessness. People learn to adjust their lives around it. People learn to develop coping mechanisms. Some of those coping mechanisms are physical, some of them are mental, emotional models that we make up. So there is this whole cognitive and mood effect that happens also, along with the physiological changes that happen. So you might have certain cardiovascular system changes that are happening to adapt to hypoxia or chronic hypoxia. There's also certain emotional and mood changes and ways of coping and reducing your activity or changing your personality that chronic breathlessness can do to you. And the thing is that we started studying all these things only in the 80s or something. So while pain is something that's been studied from the 50s and 60s, we in the dyspnea realm have been behind, and we're catching up slowly. And especially the last 20 years have been a period of great understanding and discovery about dyspnea. So I want you to look at dyspnea and breathlessness in that same framework of the physical, psychological, social, and spiritual idea of total pain that we have. You look at it as breathlessness in all those dimensions, because when we look at breathlessness as a multi-dimensional set of experiences, you'll understand that there's different type of emotions that a patient is dealing with. The context of the experience is different. My experience of breathlessness within my house versus I go to the bank office is very different, because I'm used to my house. I know how to pace myself in my house so I won't feel breathless doing simple activities. In the bank, I have to climb the stairs, I have to go up to the teller's office. All those things will change my experience of breathlessness. Physiology plays a role, age, gender, hormones play a role. All of these things also, along with that, there are acute exacerbations that patients face. So those also bring in fearful experiences. And that's mainly about catastrophizing and anxiety and sheer panic that comes. When we talk about the worst pain, sometimes we talk of the worst pain, we feel like, oh, the worst pain is I'll pass out. I just can't stand it anymore. But you can't stand it anymore. What's the worst experience of breathlessness? I am going to die. So it goes from I cannot tolerate and I want to shut off the conscious experience of it to I am going to lose my life. So that's a big jump. It's an existential threat that comes in, and it fundamentally changes you if it happens to you 2-3 times. So a patient who comes in with breathlessness, which is so severe that they need ICU, that they need bypass, some of them may have been ventilated. It fundamentally shifts a lot of their way of thinking, where they are fearful of it happening. My interest in breathlessness came, grew orders of magnitude after this very important paper came out. This is Professor Irene Higginson from the James Cicely Saunders Institute at King's College London and their group. They did a very simple study which showed that early integrated palliative respiratory care service for patients with advanced refractory breathlessness. If you started a breathlessness support service for patients, they had two groups. They randomized patients into two groups: those who will receive usual care. So whether you're a COPD patient on oxygen, or you're a cancer patient on oxygen, one group received the usual care. One group also received additional services from a breathlessness support service, which was just understanding breathlessness, understanding non-pharmacological means of managing breathlessness, phone calls from a respiratory nurse. And what they realized with that was there was a remarkable improvement in their mastery of breathlessness. The patients learned how to manage their disease better. They used emergency services better, so fewer ER visits, fewer hospitalizations, and wonder of wonders, survival benefit as well. There are very few things that give us survival benefit in medicine. It's the holy grail in all research that we do. Despite that, when you look at it, this is a breathlessness support service. This is not a big drug which is going to make money for anybody. It is a time-consuming breathlessness support service which requires nurses, physiotherapists, social workers, and a doctor who's interested in providing this kind of care for the patients. For those who are interested, this is what it can do. It can provide improvement in survival along with improvement in quality of life, because you will have less hospitalizations and most of your care can be at home. And that, I think, is a wonderful goal to work towards. So this is the reason why it's important to learn all the dimensions of dyspnea management, the non-pharmacological means, as which include physical rehab, pulmonary rehab, the use of devices, oxygen or NIV, simple things like handheld fans, as well as when the disease advances towards the very end. Most patients with breathlessness do not require opioids for very long periods of time. It's usually the last 6 months of their life that they will require opioids. But at that time, it's important that we recognize when it is necessary to start the opioids or the anxiolytics, and always try to do an integrative practice where you will use the non-pharmacological means, add on the pharmacological means, and use other alternative therapies, some of which are being studied, which may have some evidence, like things like there are things about uh, uh, mindfulness-based practices, music therapy, and art therapy. So these are supplementary things for quality of life that we can use. We define chronic breathlessness syndrome as breathlessness and disability, which is despite optimally treating the underlying pathophysiology. So, recently I had a referral for someone who was experiencing breathlessness, and it was her first diagnosis, very recently diagnosed, thought to have COPD, was being treated as COPD, and recently was diagnosed to have an ILD. So her treatment for COPD also was not yet optimized, and workup for ILD was still going on, and she experienced some breathlessness. And there was a question about whether this patient needs opioids or not. And here is the situation where you say, first, we need to make sure she has oxygen at home because this patient was hypoxic. First, we need to give her the steroids and bronchodilators. Next, we need to figure out the underlying ILD which she has on top of her COPD, and see if there is a reversible element there. Does she have a connective tissue disease, ILD, which will respond to immunosuppression? So we need to make sure that we optimize treatment of the underlying pathophysiology, put in the non-pharmacological measures, and then see about the pharmacological measures for breathlessness. As we understand more and more about the neural pathways, newer studies are being designed and newer drugs are coming up as potential for use for breathlessness. So there's studies on mirtazapine and other drugs as well, which may have multiple benefits for patients with chronic respiratory disease. Along with breathlessness, they may address sleep issues and appetite issues and things like that. So, going back to that cartoon thought that we were looking at, that, we really know as a breathlessness support service, what do we need to do? We need to understand how breathlessness affects the patient's life. We need to help them develop an awareness of their breathing pattern. most patients you will encounter very often when you tell them, do they even understand what inhale, exhale is? When they are in the situation of breathlessness, panic, anxiety, self-awareness of the body is lost to some extent. So we teach them the very simple things, like you ask them to inhale and exhale. When you ask them, you want to blow out, you tell them that, something simple like having them hold a paper and then go so that the paper stays flipped down, that's an exhale. For inhale, when you ask someone to use an incentive spirometer, they may blow out when you say inhale. So then you teach them what inhale is by using a straw and say, like, the action of sucking in something with a straw is the inhale action. So sometimes we have to simplify it by demonstrating certain things. So keep that in mind, that the patients need to develop a breathlessness and awareness of their breathing pattern. Most of them have maladaptive breathing patterns. They tend to go instead of learning how to do. So these are all the things that you have to sort of get them out of habits and practices that they've built, which are probably working against them. We teach them about pacing and positioning, trying to slow down and plan their days better so that they conserve their energy. We teach them about the use of handheld fans, which are really very, very useful for breathlessness. So just a cool mop, a cool, moist mop on the face when you're feeling breathless, a handheld fan, which blows air from about a foot away or so. And that helps to stimulate, because of the trigeminal nerve stimulation, it actually helps to stop the anticipatory breathlessness, helps to reduce the respiratory and the subjective sensation of breathlessness as well. There's other things that we teach them: distraction, relaxation. So learning progressive muscle relaxation, mindfulness techniques, all of this. And we help them to build up stamina with exercise and pulmonary rehab. So all of these are part of the breathlessness support service. Very groundbreaking work which was done out of the Cambridge group by Professor Annis Pattis's group helped create this model that we use for addressing chronic breathlessness in patients. And this is the breathing, thinking, functioning model. I think it's one of the most important models or frameworks that we have for addressing how we can help patients. So we look at these three aspects of how chronic breathlessness shifts us, right? So breathing, we spoke about how inefficient breathing leads to increased work of breathing. So this panting breathing is useless. So what we want over here is for them to learn how to do relaxation and mindfulness, and we want them to use a fan for the breathing. We want them to use breathing controllers, learning how to do pursed lip breathing when they are moving in activity, when they have episodic breathlessness, and we want them to do also incentive spirometry and breathing exercises to strengthen their breathing muscles as well. The thinking part of it is what I was mentioning earlier about thoughts about dying, past experiences, past bad experiences with hospitals and healthcare can come, which increases the feeling of anxiety, distress, and panic. And that cycle that starts off, your heart rate goes up, your blood pressure goes up, you're catastrophizing. It's only going to make the oxygen saturation drop more. So learning how to manage anxiety by doing regular relaxation and mindfulness practices. And also we help them to learn how to chant or use a mantra or use a picture, something that helps them calm down when that episode of breathlessness comes. It is to be able to convince yourself, I've been through this before. I know what I'm supposed to do. I'll get out of it again. And that can help a lot. And when it comes to functioning, the part that I was speaking about earlier, that how isolation happens with chronic breathlessness, with oxygen use, with, what will happen is mummy has bad ILD and she gets breathless, her oxygen level falls. She wants to help her daughter with housework because she feels I've become a useless person in the house. So she decides to go and make some snacks for somebody. She goes to the kitchen. While walking to the kitchen, she gets really breathless, and then she's wheezing and she's breathless and she's huffing and puffing, and she nearly collapses in the kitchen. Daughter comes and sees her in the kitchen, immediately gets a stool, makes her sit down, fans her, and tells her, why do you try to do all these things, Mama? You know I can handle it. Now, what this will end up doing is just make her feel worse, right? The functioning part, when we stop functioning, so then she'll start getting restricted to the bedroom, to her room and a television. So she's not walking as much. So her limbs get deconditioned and the breathlessness will only worsen. And the reduced activity will mean that she's more isolated, taking more help for it. So we want to try and keep them functioning. So it's very important, especially in the part of functioning, that we include the caregivers in our teaching on this as well, that they have to continue to give that person a sense of, I am still a part of this house, I'm a contributing member of this household. So whatever activities that they can do within their capacity, they should continue doing. And exercises are to either try to improve the amount of activity they're able to do. And as the disease progresses further, you may not be able to continue all activities, but you continue exercises for symptom management as well. So the breathing part has to be optimized, the thinking part has to be optimized, and the functioning part has to be optimized. We keep shifting the goals up and down. The patient is perfectly well, and we are trying to increase the amount of activity and productivity that they're able to bring. If the patient has high symptom burden, then we do all of these things to reduce symptoms. So that's the thing that shifts. The approach is the same, our goals may be slightly different. So this is, as I was mentioning earlier, the breathing, thinking, and functioning, about the approach to it, whether it is to improve exercise tolerance, endurance, and or to reduce symptoms. So these are just simple images of what positions. Very often patients don't realize that they're sitting in the wrong position, or simple positioning can help relieve that sensation of breathlessness, offload the diaphragm. So when you show them images like this, that if you're walking and you are feeling like I'm suddenly breathless, you just lean against a wall. If you're sitting on a chair, lean forward so then your stomach falls away a little bit, or put your head down on a pillow, lean on the back of a chair. Those are the kind of simple things that we can show them that they can use to help them in their house itself or in their normal day-to-day activities. It's important to distinguish between wheezing and stridor. Patients with cancer will sometimes have what sounds like wheezing, but stridor is an inspiratory sound and is usually indicative of an airway obstruction. Wheezing is typically an expiratory sound. So when we're auscultating them, it's important to also keep in mind, especially if you have patients with cancer who have COPD as a baseline, that you're used to hearing the wheezing, but also be monitoring them for any airway pathology that might be coming up. We optimize the medical treatment of the underlying condition and then assess and see if there's any other intervention that's needed for them. In today's, specialty centers across India, there are many centers which offer interventional pulmonology services. And if a patient has an airway obstruction due to tumor, then there are modalities available to treat them, which is with tumor debulking and airway stenting. Now, these may be slightly expensive, but the important thing over here is that we need to address the patient's goals of care. So what used to happen earlier was maybe it's not such an advanced malignancy, but it is a centrally located malignancy. So it's going to cause a post-obstructive pneumonia. And that pneumonia and sepsis is what leads to the death of the patient without having a chance at addressing the cancer chemotherapy part of it or the radiation part of it. What the modalities nowadays allow us to do is to buy the time for the chemotherapy to kick in. Now, this might mean something as simple as improving the prognosis by anywhere from 6 months to 9 months to 12 months. Now, that may be all that's needed for a patient to achieve their goals. It might be, I want to see my child graduate. It might be, I want to see my child get married. It might be, I want to make sure I have made the financial arrangements for my family to be safe, for the studies to be taken care of, for settle certain matters in their life. So if a patient's condition is such that it is amenable to this in interventional pulmonology is what we call endoscopic palliative care, right? These are endoscopic procedures which offer palliation of symptoms. So this is something that can be offered to patients as well. Let's take a quick look at oxygen delivery systems. It's important to know all the different ways we can deliver oxygen: nasal cannula, face mask, a non-rebreather mask. One more which has come into use a lot more and is more popularly and widely available now is high flow nasal cannula. And these are all different modalities that one can use when patients have hypoxia. The nasal cannula and the face masks can be used for home oxygen therapy. High flow nasal cannula can only be used in a hospital setting because the flow is in very high, 50 to 60 liters, so it requires hospital oxygen supply. We have different types of nebulizers available, and nebulizers come with attachments which are either a mouthpiece or a face mask. Some patients feel claustrophobic with a face mask, so they need the nebulization, but they're pulling the face mask off. A very simple thing like giving them the mouthpiece for the nebulization will also allow you to continue to fan their face, so their subjective sense of breathlessness will decrease while the drug is being delivered. So these are simple ways of combining different ways that we know of reducing breathlessness, so the non-pharmacological fan along with the pharmacological management of the underlying airway obstruction simultaneously. Patients with severe COPD, ILD, and some neuromuscular diseases will require home oxygen, and some of them will require NIV. There's different indications for this. When you keep home oxygen in mind, please keep in mind that our goal with the oxygen is to try and give them greater mobility, greater freedom. Patients will sometimes look at oxygen as stigmatizing, as something that is, they don't want to go out in public with oxygen, things like that. So it's an emotional issue, this oxygen use. And very similar to how people look at using a cane or using a wheelchair, that what will people think and all that. And we have to help them understand that this is something which is not an indicator of disability, it is something which is an enabler of greater mobility. So that is how we have to help them see it in that context. Because sometimes the fact that you're using NIV or oxygen allows you, because nowadays we have portable oxygen, people can continue to lead a productive life. Simple things can be done, like writing a letter to their employer and saying, please make sure this person doesn't have to climb stairs and is given a ground floor office. And this person can go with their oxygen and continue to work for maybe reduced hours in a day, but emotionally, that gives them a much greater sense of productivity, greater sense of self-esteem. And so you're able to address the psychosocial part of the breathlessness and how the disease affects their life. So it's not a loss of a job anymore, but it's able to continue at least to some degree, maybe in a slightly reduced hours or a slight physical change in location or something can allow them to do that. I'm going to not take much time on tracheostomy and other things because that's very specific to neuromuscular disease and aspiration pneumonia, but there are very standard criteria for when we consider it. It is better to consider early before there is significant weight loss or a lot of aspiration or decreased oral intake, especially if we think that this is a neuromuscular disease where patient still has, it's a purely neuromuscular condition and the lungs are fine and the loss of nutrition may make them more prone to illness. So it's better to address these questions early. There are very clear guidelines of when to do it by checking the FBC and things like that. Cough is a very troublesome symptom. And if you've experienced a cough, will know. I know it's that whole thing of, okay, fine, I got an upper respiratory infection, cold and cough. But if it doesn't get better than 2-3 weeks, if it's disturbing your sleep, it really affects your quality of life. It affects the quality of life of the person who's sleeping in the bed next to you also. So it is something when it becomes chronic, and especially when you see these patients with ILD who have this dry, horrible cough, or patients with bronchiectasis with severe cough, which is productive, copious volumes of sputum that's coming out as well. Very distressing symptom. Again, very multidimensional. We're starting to understand the neurophysiology of cough. Don't have too many great medications for cough, quite honestly. So there are certain drugs that we look at which are useful for cough, which are in the, which will act at the higher central level, and there are others which are on the urge to cough sensation and at the cough sensory input level. That's what we basically have right now as medications for cough. It's very important to take careful history. If there is underlying airway disease or bronchiectasis, then we treat that with bronchodilators. We treat it with postural drainage and chest physiotherapy. We look to see if there's contributing factors, whether it's an upper airway issue, whether it's acid reflux. And then accordingly, we give the therapy for it, right? So there's nothing that all patients with cough should be on. I see very often lots of cough syrups and things, right? So we have to be very targeted in our treatment of chronic cough, especially in the palliative medicine setting. That we're looking at what is the etiology of the cough. Cough can be multifactorial. So I can have a patient who has an upper airway issue as well, like an allergic rhinitis, as well as having GERD, as well as having an airway disease. That patient will require multiple things. They may need a nasal spray, they may need an inhaler, they may also need a proton pump inhibitor and a prokinetics, right? But very often I'll find that these are the things in my prescription, not a combination of multiple cough syrups. Right? So that's the part that we need to keep in mind. Explore and understand what is causing the cough, and then treat optimally for that as well. I just wanted to say, in the setting of palliative medicine and advanced respiratory diseases, opioids, baclofen and gabapentin are very useful for the treatment of chronic cough. Gabapentin is specifically the patients with chronic cough with interstitial lung disease has been found useful. Another very underutilized part is speech therapy for cough. So that's another very important modality, non-pharmacological modality that we should do. Other simple stuff like head end elevation, diet advice for acid reflux, all of these things can help with management of cough. Secretions can be very troublesome. We assess it in the standard, like how we look at pain, the onset, provoking, and palliating factors. What is the quality of the secretions? Is it like clear? Is it mucoid? Is it purulent? What is the region that it is coming from? So, looking at whether these are oral secretions or tracheobronchial secretions, especially when it comes towards patients with chronic diseases, there is a lot of production of secretions. Patients with bronchiectasis can develop very bad halitosis. Patients with neuromuscular disease can have pooling of secretions. And here, this is where secretion management is a problem. That's where the question of tracheostomy comes in. So we need to understand what the values and the goals of the family is in such situations before we offer any kind of intervention like a tracheostomy or something like that, right? There are certain devices that are available to help clear secretions. What we use commonly for bronchiectasis in patients who have a lot of secretions due to bronchiectasis is cough assist devices, and those are they basically something that you do after chest physiotherapy, after nebulizations. It helps to improve the effectiveness of the cough and clearing secretions. Noisy breathing at the end of life. People still use the word death rattle, and I have put it in over here just to say this, that I don't use the word death rattle. I say noisy oral secretions. Okay, so I would, again, this is the trying to be compassionate in our language. So we say noisy oral secretions or noisy respiratory secretions. Don't say the word death rattle. You have to counsel the family that if the patient is comfortable in an end of life situation, that the patient might have that sound, but the patient's face is perfectly calm and they are not bothered by it. We don't need to treat it. We don't need to treat it. We need to counsel the family. So you don't need to treat it with, medications to dry up those secretions just because the family is bothered by it. Right? So it's very important to keep that in mind as well. Some patients will require procedures like bronchoscopy for repeated secretion clearance. So I have some patients with motor neuron disease who have tracheostomies for long term. They might find it difficult to clear secretions and might have a sudden, lobar collapse or a single lung collapse or something. And then we try doing postural drainage. If that doesn't work out, then a quick bronchoscopy to clear out that secretion will open it up and still allow them to go back to their previous quality of life, which is at home, where they're still communicating through sign or facial expression with their family members, but are otherwise comfortable, right? Postural drainage and chest physiotherapy, an important part of clearance of secretions in patients with bronchiectasis and lots of leaking secretions. I'll just put an image in over here to help us understand these are the different positions. So figuring out in every patient's house how they will achieve this slightly hip higher than shoulder position to drain the lowermost part of the lungs posteriorly, with pillows, with help. I think one more thing that happened with COVID is so many television things about prone breathing and things like that. Now a lot more people are aware of simple ways of doing positioning at home to allow for this. And then so you do the prone position with the hip slightly higher and add on the element of chest physiotherapy, then that helps in secretion clearance. And the cough assist devices that I mentioned earlier. This is something, the big green one is the most commonly used one. It's called an acapella device. And the blue one is called a shaker deluxe. And these are two things that help a lot. The vest is not available in India. I haven't seen it. Maybe 1 or 2 centers have it. And the machine that you see with an assistant using it for a patient, that's used in India. I've seen it only used in ICUs, but in assisted living facilities abroad, they use it for chronic patients with secretion management. These are some of the devices and aids that we use for patients with chronic respiratory issues with breathlessness to help them. One is the handheld fan that I spoke about. So this one that I've shown you is, I think it's around 600 rupees. I've taken this image of Amazon. You get them for 200-300 rupees. It's better to have a 3-blade fan rather than a 2-blade fan. Tiny little battery or something which charges with your phone cable, something like that is what's available. Some of your patients may have step counters on their watch or on their phone. So you tell them to walk regularly. The more they walk, we want to improve their physical conditioning. So they keep track of their steps and you know that they are walking regularly. Otherwise, it's a very simple thing. Whatever space they have to walk, even if it is 15 feet or something, how many circuits are they making of that? How many rounds did they walk of a room or a passageway or a hallway? Help them find ways of monitoring and measuring. And then also that's an incentive for them. I walked 10 rounds yesterday. And that's more than I was able to walk last week. I was only able to walk 7 rounds last week or something like that. And this walker, which that with wheels attached in the front, a rollator type of a walker, is very useful for helping maintain their own independent mobility to bathroom and walking around. So we should encourage them to use simple devices which will keep them a little bit more mobile and doing their own activities independently. Patients who are on long-term NIV BiPAP sometimes can develop nasal bridge ulcers, especially if they have used high pressure BiPAP for a long period of time. So I like to use this ResMed nasal gel pad because it distributes the pressure and then it will not cause that ulcer on the nasal bridge, which can be very painful for patients. So this is keeping in mind that our patients' nutrition may be suffering. They are, getting lean, they're elderly, skin is fragile. Use the nasal gel pad before the breakdown in the ulcer happens. Just understanding that this patient is needing to use BiPAP for more than 8-10 hours in a day or something like that. Hemoptysis dreaded condition. Most importantly, stop all nebulization and work on cough suppression. So this is going to be primarily using opioids. Low dose opioids is what's needed for cough suppression. We use tranexamic acid IV or oral. If the patient is very anxious, a low dose anxiolytic benzodiazepine can help. The further intervention is as per the goals of care. So it depends on what is the cause of the hemoptysis. If the cause of the hemoptysis is a bleed in a patient who has say tuberculosis and it might, or an aspergilloma or something like that, which is reversible, the patient's on antifungals, is on treatment, then you go ahead and ask interventional radiology to do a bronchial artery embolization or interventional pulmonology to put in, we put in what's called spigots, which help us to buy time for the antibiotics and antifungals to work. It could be that there is a central airway lesion which is bleeding, which can be cauterized and then is amenable to treatment further with a stent, which will compress it, but it will still allow the patient 3 months, 6 months more to achieve their goals that they want. One very simple thing that, again, I learned in palliative medicine is to use dark color linens to reduce the visual distress of seeing a lot of blood every time you cough spilt out onto white sheets. So instead of using light colored sheets, we use dark sheets when a patient has hemoptysis. Pleural effusions can happen with malignancies. They can happen with chronic end organ failures like end-stage liver disease with a hepatic hydrothorax or congestive heart failure, chronic kidney disease. Some of these will require intermittent drainage, so a repeated pleural tap, but if it's filling up, if it's massive, rapidly accumulating effusions, then they sometimes need procedures like doing a pleurodesis, which can be done either through a chest tube or through fluoroscopy. And there are newer devices called a Pleurex catheter, which we insert the catheter, patient goes home with these bottles that you see attached on the top right image. And it's a vacuum bottle with a connector device, and the patient's relative can be taught that whenever the patient complains of breathlessness after 3 days, just connect one more bottle, it'll drain another half liter of fluid out. You do that repeatedly every third day, and the patient achieves pleurodesis at home itself. I mentioned briefly about aspiration pneumonia and PEG, so there's very clear guidelines on how the NICE guidelines and the American Academy of Neurology on how you plan for tracheostomy or PEG placement in patients with neuromuscular diseases like ALS to prevent aspiration pneumonia. So it's usually when the FVC drops, and if they are at high risk, moderate to high risk for aspiration, that we start planning for PEG for maintaining nutritional support early. Acute emergencies will come up despite all the optimal management of the underlying chronic disease. We should always have a plan for the acute emergency. So early on in the course of the disease, they should know what's the phone number to call, which is the nearest hospital emergency room that they're going to, what's the immediate medicines to give. If a patient has a tracheostomy, the family members are usually trained on how to check for a blocked tracheostomy tube to be able to take out the inner cannula. Having an action plan for emergencies is good. Over time, it may happen that the patients had multiple episodes and you've had an end-of-life conversation or an advanced care plan made with the patient, and they may be opting for home care and comfort care only. So it's important to know how to respond even when an acute emergency happens in a patient who has an advanced care plan that says that I want care only at home. We need to have the caregivers feel comfortable that they know what to do in that time, whether it is increasing the oxygen flow, calling in home care to make sure that they have access to opioids, they have access to support. That is what we're looking for, a plan for acute emergencies. If the plan is also that they will go to hospital but don't want to go to ICU, then keep in mind that high flow nasal cannula is an option, which has been studied in some studies for patients with end-of-life care in hospitals, patients with ILD or COPD, where the nursing requirements of the patients were high, so the patients opted for going to hospital, but said, I don't want to go to ICU. The high-flow nasal cannula doesn't cover the full face, so they're able to talk to their family, they're able to have small little bits of food or coffee for taste, for pleasure. They might be on opioids at this time for breathlessness, and you give increased access to family members for visiting. So in a hospital room, you create as close to a home situation as possible. That for the caregiver, the bereaved caregiver's experience of that once the patient passes away is also that the hospital and the doctor did everything to make sure that my mother and I were comfortable at the end of life or something like that. So high flow nasal cannula has its use in patients who have very high oxygen requirements, breathless with hypoxia, where we can transition them for end-of-life care, even in a hospital setting. Keep that in mind. Other issues that we need to address in patients with respiratory disease, I mentioned, were, there's other aspects like nutrition, nausea, constipation, all of that. So important to have fluid balance, right? Patients with cor pulmonalis, COPD, make sure that they are on fluid restriction, they are on a high protein, low carbohydrate diet. It should be sensitive to the religious, cultural, geographical context. You can't prescribe a Mediterranean diet to somebody who is used to having South Indian food. So that's basically it, that we try to find it within what is our local food, the typical choices that we make for food for breakfast, lunch, and dinner. Anabolic steroids are useful when you have muscle wasting cachexia with COPD, ILD. We use decadurabolin, can be given once a month for 3 consecutive months, and then can be repeated again after 6 months. We use appetite stimulants as well, along with the high protein diet to help with that. Patients experience nausea and GERD. So if they do experience nausea and GERD, then we should treat it. Patients experience bloating because there's a lot of aerophagia with breathlessness. So simethicone is useful for that. They experience constipation, so work with diet. If the patient, despite being on all of this, lactulose, when you put patients on lactulose for constipation, keep in mind and follow up and see, are they then getting regular bowel movements with that? If they're not, then they tend to get more bloating with lactulose as the breakdown happens. So then that's sort of counterproductive. So then just your choice of your medication for constipation shifts with that. For dry mouth, just sugar-free candy, demulcents are very useful. And chronic pain with COPD, unfortunately, our COPD guidelines don't talk about it, but 30-40% of patients with COPD will have pain as well. There's a lot of muscular pain with use of accessory muscles. They may have osteopenia, osteoporosis. They may have other things. So important thing is it's the same. You work your way up the WHO pain ladder, including using opioids if necessary, and use physiotherapy, using ultrasound, TENS. All of that is beneficial for these patients as well. The sleep disturbances come in because you might be on oxygen, noisy machines. I usually, with patients with COPD, will start with using melatonin. And if that doesn't help, then we can use benzodiazepine low doses as well. Screen them for depression and use antidepressants as needed. I've mentioned earlier, mirtazapine has multiple benefits because it helps us with appetite, it helps us with sleep as well, and it also helps us with breathlessness to some extent in some patients. Maybe half of our patients may benefit even with breathlessness improvement with mirtazapine. Just a quick word about tuberculosis. I mentioned earlier that the burden is very high. We need to keep in mind, we need to counsel the patients and family members as well. So overall, what we are trying to do is address health-related quality of life with breathlessness, with cough, with all of these symptoms. We're trying to make sure that they have as much of their idea of what a good life is, or being able to stay active and do things that they like. So you try to address professional and personal goals out here. Something that we tend to ignore is how breathlessness can impact physical intimacy between couples. COPD is, patients with COPD can also suffer from sexual dysfunction. So these are things that we do not address and talk about, but it is important that we do, especially because these patients are going to live with these symptoms for 6, 7, 8 years. So part of palliative care for patients with advanced respiratory disease is to make sure that they have this aspect of us helping them with issues with their personal relationships, with intimacy as well. So finding positions and ways in which intimacy can be maintained is important. Opioid phobia is something that with the palliative medicine group, I don't need to speak as much. I do need to speak more with my pulmonology colleagues about opioid phobias. They help in many ways. This is a wonderful paper that I would highly recommend, which is a Opioids for Breathlessness and Narrative Review written by Professor Miriam Johnson and Professor David Currow, who wrote the ERS monograph on breathlessness. And it's got a beneficial effect on every aspect, right? The anticipatory breathlessness, urge to breathe, all of it. Regular low dose sustained release morphine in opioid naive patients for COPD. For ILD patients, however, episodes, when you have episodic breathlessness, low dose, really low dose immediate release morphine is what works better. So for refractory breathlessness, this is for COPD, and for patients with chronic COVID-like complications, this is what we were using. This is taken from the Pali COVID Kerala ebook, which Pallium India had done a massive, education program across the country to help healthcare workers across the country understand how to manage breathlessness in COVID patients. When do we initiate end-of-life discussions? The surprise question, I think you might be aware of it. Would you be surprised if this patient died in the next year? As doctors who've been seeing a patient for 7-8 years, once they start having multiple hospitalizations, if they're going to the ICU multiple times, then this is happening, right? So it's time to start the conversation at that time. Ask the patient, have you ever thought of what to do when the disease gets worse? Where do you think people should spend their last days? Most of them will say that I want to be at home. Sometimes if their nursing requirements are very high and they feel they're a big burden on caregivers, that's the only time they may say that, doctor, at the end I might need to come because it might get a little too much for me. So that's okay, but it's important to have the conversation. Taking care of someone with chronic respiratory disease is highly stressful because you will have these multiple trips to emergency room with someone who's not able to breathe at all. You have to manage these multiple pieces of equipment. You have to have this plan for acute emergencies, backup electricity, you're on oxygen, you're using a BiPAP, electricity goes out, there is a big, huge power outage. All of these things you worry about. So they tend to develop compassion fatigue, burnouts. Make sure that you check in on that person who always comes along with the patient. For 7-8 years, you'll see that same person. It might be a daughter-in-law, it might be a daughter, it might be a grandchild sometimes, So make sure you're checking in on that person. They know the patient's disease, they know the patient's entire history much better. So it's very important to listen to key into what the caregiver is telling us, and we should prepare them when things are going down. So that's basically what I wanted to share with you, that, tell the patient that sometimes they think, is there anything else I can do? Is there, the caregivers will be like, am I doing everything all right? They have this huge stress of what else can I do? And so it's very important to reassure them and tell them and encourage them and say, you're doing excellent. You're taking very good care of mommy. You're taking very good care of daddy. So please keep the caregiver's courage up. And now I'm going to very quickly 1 minute of calm breathing before we go on to our case. So I want to now invite you all to again take a deep breath in. Close your eyes. Take another slow deep breath in all the way up to the top. And exhale with your mouth, making a sound blowing out. Imagine yourself to be in a beautiful and calm place. Could be by the side of the stream. You can hear the water jumping over the rocks. There's a tinkling sound. There's a lovely breeze in the air. You imagine you can feel the breeze on your skin as well as the sun on your face. Be still. Breathe at your own pace. Be calm. Raise your shoulders up and then drop it down. Relax your muscles. Make a nice soft sound. And now, I want you to slowly open your eyes. Thank you. With that, I'll stop my presentation. And I'm happy to go on to, I know we have a case. I'm sorry, I probably took up more time.
Thank you very much, Dr. Rajani. Sri Priya, as it was an excellent presentation, Dr. Rajani. We'll have the discussion after the case presentation because the case presentation is also ready. We'll just go ahead with that as we're running short of time.
Good evening, all. Am I audible?
Yes, Dr. Surya, you are.
I am Dr. Surya, anesthesiologist in Maulana Hospital. My case is about a 45-year-old male with a diagnosis of a right non-small cell bronchogenic carcinoma of stage 3B. His presenting complaints was breathlessness and cough, chest pain, facial puffiness, swelling in left axilla and left side of the neck. History of illness. He is a non-smoker for the past 25 years and he had a history of weight loss for past 1 year. 8 months back, symptoms started as a persisting dry cough along with the tiredness and bilateral lower limb edema and pain, for which he had taken treatment from a clinic for 1 month, but the symptoms not subsided. Later, he developed facial puffiness, swelling in right side of the neck, increased tiredness and loss of appetite along with cough. He was investigated with chest X-ray which showed right upper lobe opacities. Then CT thorax and neck was taken, biopsy taken, and came to the diagnosis of a CLM. Now his presenting complaints was breathlessness, which was moderately severe, grade 3 according to modified MRC classification, more during evening and night, and it was associated with cough, usually dry and occasionally with a mild sputum, blood tinge. And these symptoms got exaggerated for the past 2 days. He is anxious and worried about his disease and family's future, which caused more breathlessness and inadequate sleep during night. He is comfortable in lying down position with the propped up position, and he is having only little improvement with the bronchodilators. He is also having chest pain, which is generalized, and he is saying that he is having a feeling of chest tightness, which is moderately severe. He is having facial puffiness, which got increased for the past 1 week. And 1 week back, he also noticed a swelling in the left axilla and left side of the neck, which is hard in consistency. He is also having tiredness and loss of appetite. On examination, he is thin-built and nourished. Facial puffiness was present. He has a swelling in the neck with a healed scar. Pallor was present, grade 3 clubbing, right and left supraclavicular lymph node, and the left axillary lymph node was present. Bilateral pedal edema, and his vitals was heart rate of 90 per minute, BP 120/70, saturation of 92% on room air. CNS CVS appears to be normal. Respiratory system, he appears to be tachypneic. He's seeing chest tenderness. Right side air entry was decreased. He was having wheeze and occasional creps. Treatment and significant investigation. CT thorax and neck showed a right upper anterior segment, paramediastinal soft tissue density mass lesion of 5.2 into 4.3 centimeter, SVC compression, and collateral venous channels noted in the right upper anterior and posterior chest wall and neck region. Multiple enlarged nodular lesions noted along the right lower paratracheal region. FNAC of the right supraclavicular lymph node showed clusters of atypical cells suspicious of a mets from a poorly differentiated carcinoma. And he has undergone 6 cycles of palliative chemo and was advised to start radiotherapy. Chest X-ray showed bilateral pleural effusion, more on right side, for which pleural tapping was advised. Oxygen, corticosteroids to reduce the peritumor edema, breathlessness, bronchodilators, and analgesics were given. Psychosocial aspects. He is a 45-year-old young married man with his mother who is having diabetic foot and 2 children of age 14 and 10 years, and his wife and younger brother. Source of income is from his wife and younger brother who works on daily wages. He is anxious and worried about his disease and his future. Both of his children are young and he is worried about their future. And now he is having a guilty feeling about his habit of smoking, which might be the cause for his disease. And he is also feeling depressed because he is not able to look after his mother and family. Medications that were given was for breathlessness and cough, corticosteroid, bronchodilators, antihistamines, morphine for breathlessness and pain, tramadol, anti-anxiety drugs like benzodiazepines, amitriptyline, antiemetics, PPI, laxatives, and multivitamins. Main concern is about breathlessness, pain, anxiety, financial issues, and future of his children and family. Summary: 45-year-old non-smoker with a diagnosis of adenocarcinoma right lung, stage 3B, presented with complaints of breathlessness, cough, facial puffiness, and lymphadenopathy. Showed right-sided pleural effusion and SVC obstruction on investigation. Treated with pleural tapping, corticosteroids, bronchodilators, anti-anxiety drugs, antihistamines. Discussion points: smoking awareness, breathlessness, about the non-pharmacological and pharmacological treatment and surgical interventions. Thank you.
Thanks for
Thank
sharing
you
this
very-
piece, Dr. Surya.
Thank you very much. First, let me thank both Rajani also for the excellent presentation and a detailed discussion on all important points. As you mentioned, being in intensive care, or all of us are interested in doing all intervention. As she mentioned, I have also done intensive care from my like medical school till uh, nearly 25-30 years. So, but that help makes you think everything can be sorted. But at the same time, opens up your eyes on how much of awareness has to be imparted to the family. One thing which I would like to add on is, many times many family are worried, oh, have I not done everything, or am I giving up, or is it me giving up? For that, one thing what we generally say is, many times it's a medical decision. It is not the decision made by them. Just by telling that statement that it is a medical decision, it's not you making. We have seen patients like this for 25 odd years. We have done everything every time. In spite of all that, also, there is no response. So this is something inevitable. If you just explain this to them, they are 200% relieved. So that blame, that blame of fear what they have, oh, I should have done, I have not done, that is taken away. So this is something like a take home, because they have to be informed that we have done everything, this is what it is. So still, next important thing, as she mentioned, you're telling, don't think that you're going to give up. We will keep them pain free, we will keep them comfortable, we will look after all their symptoms, we'll give them maximum dignity, you can be around. If you tell all this, they will feel so relieved, they will be together. So understanding and conveying the message and making sure you are going to do everything for each symptom that they are concerned. So that is from our discussion. And few points like cough and these things, not only for respiratory patients, any elderly can have all these symptoms. So looking into these things, and looking into, especially with cough, you have to see what are the points. Many times it could be a gastrointestinal. You saw that patients' personal things, like if they have a full meal and they go to bed immediately, they can end up with cough. Elderly can have hiatus hernia, which is very common. So these are things that you have to understand, take home every day. See, nearly with so many sessions, total pain management, everything, look into everything. Don't look at one symptom alone. So start looking at the patient as a whole. This we are taught every time. Only thing, we have to constantly remembering it, reiterating it. So that is from our main presentation today. And regarding the case presentation, what exactly was told is what our case presentation has got. So really very nice, and thankful for your case presentation, because in the explanation, Dr. Rajani mentioned about guilt, and that's what you have brought in your case. So like that only you have to see and relate. So from now on, I would, either you can unmute and ask, or go ahead and type in the chat box, whichever each one of you feel comfortable, and we'll go into each points. What I would ask Dr. Rajani to go through the discussion points with our team, who are generally, they come up with their queries and suggestions too.
So if I can just quickly share in terms of
Go ahead.
smoking awareness and guilt alleviation here. Patients suffer from extreme guilt, as we mentioned over here. So one of the things is, now is not the time for us to bring up anything about smoking with him. This is our time to say that there are patients who do not smoke, who have never smoked, who also develop it. So yes, that was in the past, but we could try to help him to switch that fixation of thought on guilt, because guilt is a negative emotion. Regret is something which leaves room for some positive action. So I regret that I smoke, but I'm going to try to follow certain things so it's easier for my family to take care of. So you just help him to focus on that. That if you do these 2-3 things, it will be easier for your family to take care of you. So that's one thing that you can do. Where breathlessness is concerned, non-pharmacological and pharmacological treatment. For this gentleman, he's got very advanced. He's already got SVC obstruction, which is usually a pre-terminal sort of an event in patients' lives with such advanced cancer. So we have a very short period of time. it's very important that we optimize the non-pharmacological and pharmacological treatment for him. So very simple things like making something that I do, like when I do home care visits, is to sort of rearrange things so that their effort is minimized for things like going to bathroom, a chair, where they can still be accessible to the family, still be able to talk with family members, be part of the family while being stationary as much as possible. So just little things within a room design or the home design helps them still be engaged with family, not feel that isolation so much. Use of the handheld fan would be very useful for this gentleman. Keeping images. We talk about spiritual stuff, right? At this time, when he is facing guilt, sometimes spiritual beliefs and faith and all of that can help them get over that guilt. So, for some of our patients, just keeping, helping them with prayer beads or keeping a prayer on a poster that's in front of them, an image of their beloved God. If they are agnostic, a-religious, a beautiful scenery of a mountain, a seaside, right? So it depends on the patient's belief system. That will help them get away from that guilt that is there. That I am part of nature, it's okay, it's fine, right? So use all those non-pharmacological means. When the pharmacological treatment of breathlessness, you're already using the steroids, the bronchodilators, you're giving opioids for the pain. When we talk of opioids for pain, we also we can increase the dose of opioids to help alleviate the breathlessness if you have already achieved optimal doses of the steroids and the bronchodilators. Okay, so typically patients can have an increase of, if they've achieved pain relief and they're still breathless, you can increase the dose by about 10%. Anywhere between 10 to 20% increase in the dose gradually to achieve relief of breathlessness. In this patient, I would not be hesitating at all because, like I said, this is FBC obstruction. He doesn't have that much time. So it's important to make sure that his breathlessness is well relieved at this time. You also mentioned symptoms of depression, don't feel like eating, not sleeping well. So rather than anxiolytic, an antidepressant would also be useful over here. That's my feeling. Any other thoughts, Dr. Radha ma'am?
I see, as you have mentioned, you have gone into everything and you have given us a detailed explanation on pharmacological, non-pharmacological, the breathing techniques, like the breathing, thinking, performance, the cognitive behavior, thought, action, and how we do things. So it is the thought which decides on what action you do. So you replace negative thoughts with positive thoughts. That is common thing. And mindfulness with breathing. Pursed lip breathing is what, I'm a chronic pain physician too. So that is something is being taught. And in our session, we have 2 practical sessions also. So all of you, please, that is equal inhale, exhale. Please teach these things to all patients. Inhale, exhale equally, and pursed lip exhalation, we say that normal inhalation and pursed lip exhalation, which is being taught, that helps really very well, calming them down. So those are things which will be helpful. And every day, morning once, evening once, I used to teach them, you have to give 10 minutes is my happy time. Among all your nonsense, these are all good for each one of us too. So like we have scheduled time for all activities. This is my running time. This is my gym time. You have happy time too. 10 minutes more in the forenoon, 10 minutes in the afternoon, everyone's life. So teach all these things to patients. And one more thing I would say, the picture which had all the positions, please teach them. These are all very simple things. In palliative care, we teach sit-stand exercise. If someone says, I can't do anything, we just tell them, just sit and stand in your chair. So like that, you remember all those positions which was shown during our talk, they come very, very handy. Oh, they wouldn't have known. See, many things, awareness, we have to raise awareness to a very great extent. So please remember and tell them, and they will say, oh, is it so simple, which I was not aware of. So they would say, oh, like once you tell them, and next time when they come to you, you will see a big difference. I would say an ocean of difference. They would have felt so much comfortable. Oh, I was not aware it could be solved so easily. Like, like this for respiratory symptoms, there are even simple exercises for like chronic back pain and things which we teach them. So like that, everything can be, you can have pharmacological, non-pharmacological, simple day-to-day means of changes, and do tailor-make changes to that patient. Change the room, change their like from room to kitchen, and then tell them, rather than them doing things in one room and the family being in another room, bring everyone together. So these are things, no? Every session what we have, all of you, like what I say to patients, I will tell you one simple thing. All of you are attending 20 sessions. If you don't compile all these and keep, we can forget. Okay, we are all bound to. So put everything in one place, because so much of like treasure of information you've all had. So, and then keep it, and then go back to that and use it for each patient. Because nowhere, no Google will be able to give you all this. Don't take me wrong, Google has everything, but it does not have, it's not end and all. So all information, so many 20 brains and 20 brains, so many 20 hours of each presentation, you're all benefiting. So like that, compile all these and create, and it will be very, very helpful when you actively practice palliative care. Palliative care, I think everyone will be interested, and it's something part and parcel of medicine. Anything else is there in the chat box? Let me quickly have a look. No. Or somebody wants to unmute and ask, do feel free to ask.
Hello, ma'am.
Your talk was why? Go ahead.
Dr. Amar here from Mumbai.
Okay.
Hello, Dr. Ram.
Yeah, since 1 decade, I'm working in TB, in TB hospital, Chudi.
I trained there in my MBBS days. Yes, we used to have a posting there.
Okay, much. Yes,
I'm
I
from
had a work
Lokmanya
under
Tilak.
Dr.
Yeah,
Dr. Khatri, Dr. Atole. I have worked over there. Okay. So, my question is, Mumbai is capital for TB in the world, I think. And we see MDR, XDR commonly over there, and TDR. Even though we are knowing that patient is completely drug resistance, then also we give antibiotics, and they suffer from very serious side effects. And
Peripheral neuropathy, depression. Yes.
what is the exact role of us? Have to give antibiotics till they are resistant, and they are still suffering. They are begging for the death. They are begging for the oxygen. And even the stigma is there. We are not able to touch them. We never ausculted them. Okay, many of the times we don't touch them because we are knowing that he is suffering or she is suffering from the TB. And I just want to answer the patients that when they ask, doctor, what if I don't take antibiotics, though it is not working? It is good enough that I'm not taking antibiotics. I don't want to take antibiotics. I want to live my life like this way. What to do in that situations?
You know, Dr. Amar, I hear your pain, and I really appreciate you sharing this, because I can see how this is a burden you've been carrying, right? You've been serving these patients for so long, and these are the stories that we carry. Now, palliative medicine and palliative care for drug-resistant TB has been a controversial issue because they look at it as we are saying, because of the prior notion that palliative medicine is about giving up, right? Palliative medicine is an extra layer of protection that we add for the patient. These patients have symptoms which we are not able to address. And as you said, it is like chemotherapy for a cancer where the cancer is not responding to the chemotherapy. And all the patient is getting is the expense of the drug and the side effects of the drug. In India, we are yet to frame proper policies and guidelines about palliative care for drug-resistant tuberculosis. There's a national effort that is underway, which has recently started. South Africa is the one country which, like us, has a very high volume of drug-resistant tuberculosis. So they actually have a national program with palliative medicine and hospice support for patients who have drug-resistant, multi-drug resistant TB. So they have hospices where patients, so there's a multidisciplinary team where the TB expert will discuss with the family caregiver, patient, and the palliative medicine expert, and we recognize that this patient is not getting better, has completely destroyed lungs with tuberculosis, and is, like you said, breathlessness, pain, depression, and they just don't want the suffering of the medicine anymore. So there are those hospices these patients can be taken care of in. We have yet to find the public health answer, even in private healthcare. Believe me, I have spoken to a lot of people who've worked in tuberculosis. This is an area I've been knocking on doors for trying to expand access to palliative medicine for drug-resistant TB. Radha ma'am, Dr. Sanjeev Nair at Kerala, who's also part of the National TB Task Force, is, he's one person who's been championing the cause of improving access of palliative medicine for drug-resistant TB. So, Dr. Amar, I would love to connect with you. I'll take
Yeah,
your
actually,
contact information.
today I am in Kerala, madam. I am just attending 6 weeks program over here, and
so we are in the process of putting a team together of people who are interested in palliative pulmonology as well as tuberculosis, and we would like to make sure that there's simple and actionable guidelines for when we decide to de-escalate therapy. And so there has to be an overlap, right? Palliative medicine begins right from the diagnosis of drug-resistant TB. And if it becomes that the medications aren't working, patients been on meds for months to years, then it's about reducing the antibiotic and increasing the palliative medicine coverage that you're providing to the patient with home care. So that's the sort of approach we will be taking. I'll be happy to connect with you and tell you how to explore this.
Okay.
So we would like request Sripriya to make sure that you share Dr. Rajani's contact details, which would be ideal for him to get in touch. Because as I keep telling, this is a platform. God's grace, we have got people who are willing to go out of the way and help. Okay, so please utilize this opportunity. And when you've got contact with people like Dr. Rajani, so it might be helpful for him, and in turn, he would help more people. It's not him.
I have access to far fewer patients than Dr. Raman. He will transform far more lives. I'm sure of that.
That's why it's all always like, as I keep telling them all, that they've got more friends. So like that is how. So each one will be able to practice better off and feel self-satisfied and soul-satisfied. And in turn, we'll be also able to help them, and it will help us also. So it's not one direction, it's a bi-directional happiness or satisfaction. Yes. So that's what. So hopefully, I hope he gets in touch. Sripriya, make sure that it is he's able to get all the deal. Anything else is there? No, if not, if everybody is happy, we are really so thankful to you, Dr. Rajani, for enlightening us. It's as you said in the beginning, I too feel the same. It's a nice opportunity. I would say we all have to thank Pallium India. Pallium India is what 5 years ago brought me into this. So I'm so grateful to Pallium India as a whole team. So in their front, I would like to thank you and thank one and all for everyone in participating today too. And hope we will meet all of us again. And I'll pass it over to I'll pass it over to you, Sripriya.
Thank you, Dr. Ratha. Thank you, Dr. Rajani, for joining us. As usual, one of those breathtaking sessions on breathlessness, if I could say so. Thank you so much.
Thank you, Sripriya.
I will ensure that Dr. Amri is getting the details to connect with you. So with that positive note that this pattern of palliative care, which we have enlightened, keeps circulating around the world in your places and reaches the needy. This is Sri Priya, along with Dr. Rajani Surendar Bhat and Dr. Ratha Venkateshan, signing off from the Tips Eco Hub. See you in the next session with another eminent faculty and an industry topic. Till then, everyone, take care. Bye-bye.
Thank you.